Welcome to the video on bioequivalence study basic terms. It is a part 2 for this video series, and we will talk regarding the pharmacokinetic terminologies in this part 2. So let's have a basic look for pharmacokinetics. Whenever the drug is administered, it goes through the pharmacokinetic route, that is absorption, distribution, metabolism and elimination. For oral route, the drug is mainly absorbed from the small intestine. It gets distributed through the portal vein, through liver, and then it is eliminated. So absorption from intestine, distribution from the blood vessels, then metabolism mainly through the liver, and excretion mainly through the urine. Other routes of excretion are also there. Other route of metabolism are also there. Our drug may get metabolites in different organs, but the principal organ is liver. So absorption, distribution, metabolism and elimination are the pharmacokinetic stages. So let's start with the key terminologies. Many of the professionals don't understand, or they find difficult to understand these terminologies. So this video is for those people who are having difficulty in understanding these terminologies, and also for those professionals and students who knows these terminologies, and for them this video is as a refresher video. AUC, it is nothing but area under the curve, and from where this area under the curve is coming. So consider you have given a tablet formulation. Consider it as a immediate release type of tablet formulation of any drug to the patient through the oral route. That tablet will be swallowed by the patient with water or milk, and then that drug will go to the stomach. In the stomach, the tablet will disintegrate and the drug will get dissolved after some time, based on to the drug properties and based on the formulation property. Then once the API is in dissolved state, that API will get absorbed into the blood. Then that API will get distributed throughout the body, and after certain level of absorption and distribution, that API will be excreted from the body or eliminated from the body. Now in bioequivalence studies, the AUC is calculated from the drug concentrations after the blood samplings. So you have given a tablet to the patient and you keep on taking the blood samples to understand the drug concentration in the blood. So you are studying the drug concentration. Here the drug is taken or drug is administered, then that drug will be absorbed into the body through the intestine, and after some time that drug will start excreted, or it will get excreted and its elimination will happen. So suppose you have taken blood sample here, blood sample here. Throughout the AUC time, you have distributed the blood sampling and you have taken the blood samples. Now you are getting the blood sample results in microgram per ml. Blood samples means it is a plasma sample, and you are calculating the area under the curve from those results. So area under the curve is the total exposure of the drug in a specific time period. For example, here is time 0 and here is time 24 hour for example. So this area which is coming this under this curve is called as the AUC, and AUC is the overall exposure of the drug in the body. So this area is the AUC. Now what type of information is taken from this AUC? So AUC assesses the drug extent, its absorption, distribution and elimination. So this area is related to the drug absorption phase. This is the absorption phase and this is the elimination phase. So if you make it half here, then you will find that till this point the drug is getting absorbed, and after completion of the absorption then the drug starts or it start eliminating from the body. So this is the Cmax. We will see this in the upcoming slide. So AUC gives you the information regarding the extent of drug absorption, distribution and elimination. AUC is affected by the rate and extent of drug dissolution. Drug get dissolved and it get absorbed. So if it is fast getting dissolved faster, then your Cmax will be reached at a faster rate. Then elimination, the extent will depend on the elimination. Generally AUC is 0 to T, that is specific time point. So if you make here a time point like 1 hour, 3 hour or 8 hours, then you can get the AUC up to that point also, that is AUC 0 to T and AUC 0 to infinity. So infinity means till the last observed concentration is taken for the blood sample, and the remaining part is extrapolated from the rate of elimination, or it is called as elimination rate constant. So that I will cover in the upcoming videos. Its unit is generally μg per hour per ml or mg per hour per liter. This is regarding the AUC. AUC gives you the information about the extent of drug exposure, whether your dose is getting absorbed into the body or whether the patient is receiving the proper dose or not. If the formulation fails in the dissolution, at times it will be reflected in the AUC. For example, if you are doing bioequivalence study comparing the test formulation with the reference formulation, then AUC is required to be in the specified limits of 80 to 125. So AUC is a pharmacokinetic parameter for bioequivalence. Now coming to the Tmax. So here you are taken the drug, it is getting absorbed, and here it is showing the peak plasma concentration. That means the maximum concentration in the blood, and the time to reach this point is called as Tmax. So time required to reach the maximum drug concentration in the body is called as Tmax. Example of Tmax is like 0.5 hour to 2 hour for some IR formulations. Tmax is affected by the dissolution rate. Then coming to the Cmax. So Cmax is one of the pharmacokinetic parameter which is to be within the specified limit of 80 to 125 for bioequivalence. Cmax is the highest drug concentration, microgram per ml or mg per liter may be the unit. Cmax is the highest concentration of drug in the blood. It is called as peak drug exposure level, peak plasma level or maximum plasma level. It denotes the rate of absorption and it is mainly affected by the dissolution rate. Time to reach the Cmax is called as Tmax. So Cmax means the concentration max and Tmax means the time to reach the Cmax. And one terminology is also there, that is Cmin, that is minimum drug concentration. So after completion of the elimination, minimum or lowest drug concentration in the blood will be called as Cmin. Then T half. T half is the main terminology, and based on the half-life of drug, the dosing is done. The formulations are made in IR or ER type of formulation, and also the bioequivalence designs are made. Time required for the drug level to get down to half of its maximum concentration level is called as T half. So here, as I have shown, here is the Cmax and this is the T half or half-life time at which the drug has lost half of its maximum concentration. So the drug may have short half-life or drug may have long half-life. Metoprolol is having a half-life of 3 to 4 hours and aripiprazole is having the half-life of around 75 hours. So metoprolol is called as having a short half-life and aripiprazole is having a long half-life. Then volume of distribution. So many of the professional don't understand this terminology. Volume of distribution. For example, you have given a drug to the patient and it is undergoing the ADME phases, that is absorption, distribution, metabolism and elimination. If drug got absorbed into the body, it is in the blood and that drug is moving with the blood throughout the body. If that drug is getting stuck or getting bind to protein or getting entry into the fatty tissues or organs and it is not coming into the blood, then it will be there for a longer time and it will be not available in the plasma. Just I am trying to explain you in the layman language that if the drug during its distribution throughout the body is going into the fatty tissues or organs or getting bind to the proteins, then it will not be available into the plasma. Now VD is the apparent volume in which the drug is distributed in the body. So if the drug is not having binding to the tissues or not having binding to the plasma proteins, then it will have small volume of distribution. And if it is getting binded to the tissues or getting distributed into tissues or getting more bind to the plasma protein, then it will have high volume of distribution. Here we should understand that the drugs which are more lipophilic in nature will be having higher affinity towards the binding to the fatty tissues or binding to the or distribution into the tissues, and the drugs which are hydrophilic in nature will be having less affinity for binding. These hydrophilic drugs will be available more in the plasma and that's why they will have small VD. So high VD means the drug is distributed in the tissues and it is less available in the plasma, while the low VD means the drug is distributed less to the tissues and more in the plasma. So volume of distribution is somewhat reverse type of definition. If the drug is available more in the plasma, then it is having small VD. So now you should correlate the VD to the elimination. If drug is having high VD, it will be having low elimination. And if the drug is having low VD, that means the drug is distributed to less distributed to tissues and it will be more in the plasma and it will be eliminated from the body. Now once again you should relate this to the T half. If drug is having high VD, it will have long T half. If drug is having low VD, it will be having a short T half. So propranolol is the example I have taken here. Propranolol is having 4 liter per kg or 320 liter, that is large VD. Phenytoin is having small volume of distribution, that is 0.75 liter per kg. But these terminologies, as I have explained, with the relation between the VD, lipophilicity and the T half, will not be applicable to each and every drug, because there are more ways for the drug metabolism, drug distribution and elimination. But generally the drug with high VD will be having higher T half or will be having the longer half-life period. So then coming to the clearance. So as we have understood that absorption, metabolism, absorption, distribution, then metabolism, and now elimination. So elimination, clearance is related to elimination of the drug. It is the rate of drug elimination from the body, or you can say it is a removal of the drug from the body. So all these pharmacokinetic parameters are related to the safety and efficacy, and that's why the Cmax and AUC are mainly considered as a criteria for bioequivalence. The safety and efficacy of the drug product is related to the pharmacokinetic parameters of the drug and the formulation. And these all parameters are considered for bioequivalence, bioequivalence study design, and the bioequivalence study protocol. So I hope you might have got some learning out of this video. I request you to forward these videos and share these videos in your friend circle. Thank you.